Firstly, Salah, thank you so much for having me. I don't know where he is. Can't see anything around here. Thank you very much for having me. It's an honor, it's a pleasure to be here amongst friends. I think it's just the most awesome thing in the world, and I look forward to meeting you all in the bar tonight, because I think tonight's the first night that my jet lag's fine, that I can start drinking again. And I promise you, when I drink, I get much taller, I get much sexier. Every woman loves me. I'm strong as hell. But it's really, really cool to be, and it's cool to be amongst my friends here. And for those of you who've stayed for this late session, thank you. It's an honor that you've stayed here. We're going to talk about optimizing hard and soft tissue in the aesthetic zone, and really I'm going to change track completely. We've seen a lot of great work by masters who have taught me and who have done things for many, many years, who are supremely skilled. And in their hands, a lot of the stuff that they do works with ease, and you've seen fantastic work. And what I'm going to do is I'm going to pull it back a hell of a lot, because a lot of times when we as the younger generation try and do things in the same way that they do, we tend to burn our fingers. We might get one case that's right, but the problem is that's the other 9 cases that we don't get right. And I think that's the critical issue, and that's where I'm going to spend most of my time, is using science and using some of my experience of 20 years of implantology to try and share with you what the step-by-step protocol should be when we are placing implants, when we are enhancing things. Not so much in the dense arbor. I'm not going to spend a lot of time with it, although it is my way that I do my drilling these days is the dense arbor, and I will utilize it in some ways. But what I want to do is I want to show you how we cross the I's and dot the T's, because I think that is really the core to success in implantology. And we are talking about long-term success. We've seen a lot of stuff in the last few days showing fantastic stuff where we jump in, we get the stuff done, bada bing, bada boom, everything's finished. But the key comes down not to what happens on the day, the key comes down now to what happens in 15 years' time. And 5 years these days is not good enough anymore. We want to know what's happening in 9 and 10 years, because the funny thing is for those of you who've been doing implantology long enough, sorry, can you switch that projector off? Can't see. Kidding. I'll just go stand over here. Because if what happens is, what we find is that at 9 to 10 years, that's when things start to go pear-shaped. That's when things start to fail. That's when the bone starts to resorb. And we see a lot of stuff on the podium. We see a lot of people showing a lot of fantastic stuff. Remember, we get paid. Okay. So don't believe everything that gets shown to you. All right. And we'll talk about some of those things, about what happens. So let's take this to the next level, and let's talk about what the patients want. Okay. And Bernie was great, because he led me into this whole thing, and he kind of directed it in there. Bernie, great lecture, and thank you very much. But in essence, Bernie said in the beginning of his lecture that patients are coming in, they're not looking for implants, they're not looking for bone grafts, they're looking for teeth. Okay. And the issue around teeth, and Jack put it so beautifully, I think, Jack, the one thing about South Africa is that we don't have people coming in with a Chewbacca, they come in with an AK-47. Okay, so you'll understand why we have to be a little bit more careful. Okay, it's that big panga is not so cool when they come in with a big panga and the huge guy behind. Okay, and I'm only a small guy, I'm not as big as you. Okay, but the essence is, okay, and Versah showed this very, very clearly, that a lot of aesthetics and a lot of long-term aesthetics is related to the pink. And what I'm going to do in this lecture, I'm going to show you step by step how I worked and the techniques that I've worked through over the years to try and create the best pink that we can. So that when the restorative dentist gets the opportunity to do their restoration, things are as perfect as we can get them. And that's what's key. Okay, perfection, but not perfection for the first year. We wanted perfection for the first 5 years. And there's a huge difference to treating an 80-year-old towards treating a 20 or 25-year-old, because that 25-year-old is going to have another 70 years with that implant. So 10 years is not enough. So let's look at the issues that we have to look at. Let's look at the key factors that we have to develop. Okay? Bone, soft tissue thickness, and attached gingiva. All 3 of those are key to success. And there's a lot of new data, which I'll go through in a minute, which shows the symbiotic relationship between bone and soft tissue and how the one protects the other one. Bone protects soft tissue and soft tissue protects bone. So it's all very well if you're a great surgeon, but you can't do soft tissue. And it's all very well if you're a great soft tissue surgeon, but you can't do bone. You need to be able to do both. And that's the key. So let's look at the literature. Let's look at the bone. Okay, let's look at bone. What do we require? Because these are key issues. We've spoken about expanding bone. We've spoken about things. We haven't yet mentioned what the key needs are. What do you need to keep everything stable? Because putting an implant in and having only the shoes and socks in the bone and saying that's a successful implant, that is not a successful implant. It will last for a while. It will function for a while. But eventually it's going to collapse. So we know from Spray, and he says that as the bone thickness approached 1.8 to 2 millimeters, bone loss decreased significantly, and there was some evidence of bone gain. So what he was saying now is that with each implant, we require at least 2 millimeters of bone on the buccal and on the palatal. Now think about that for a second, because we'll look at Uli Grunder's article, The Influence of 3D, December International Journal Dentistry 2005. He said to avoid losing bone height, the bone thickness needs to be between 2 and 4 millimeters. If this amount of bone is not available, part of the buccal bone plate will be lost after remodeling. Think about that, 2 to 4 millimeters. For those of you who've placed an implant, how many here this week have actually had a site where you've put the implant in where there's 2 to 4 millimeters on it? Put your hands up. Show off. Okay. Not a lot. Okay. And Jack, I think he said he's talking. You have to listen to my lecture now. You're not allowed to sit and talk through it, eh? Is that Chewbacca? R2D2. That's that little robotic thing. Got it. Yeah, and that's the guy next to you. So the essence is we don't get too many of those cases, and more often than not, we take a 4 millimeter implant and we squeeze it into a 6 millimeter ridge. And Salah, what I love about what you said, which is I think shows true integrity, because unfortunately we get bullshitted by the trade. And I say that openly and honestly. We get lied to left, right, and center, because if you just slap at a bit of bone, put this little membrane on, whoa, you're going to grow bone. And then we all go and we get told by the experts, key opinion leaders say, look at my cases. Whoa, fantastic. And then we go home and we try that case, and 1 out of 10 cases is actually successful. The other 9 we actually can't show anybody because it's too embarrassing to say. And then we think it's our fault. But in actual fact, the key opinion leader's just done more than you, so he's got 5 out of 10. So he can show a few more cases, but he's also got the bottom drawer cases that he can't show. And what you said, which is so important, Salah, was the fact that despite the fact that you are expanding the ridge, you still have to develop the bone. Nothing has changed other than you are improving the bone. You're making it better. Okay? You're giving it a little bit of Red Bull. Okay, and that's essentially where we're going with this. So if we look at what we're looking at, if we look at the amount of bone that we're trying to create, okay, because I want you to take your head and start looking at it in a different way. You need to start developing your bone more than you used to. And this is where osseodensification comes in, along with the grafting techniques that go with it. You'll see different types. Homily Wang's technique, the sandwich technique, which is the classic. We just add a little bit of bone. We put autogenous bone, xenograft, membrane over, bada bing, bada boom, we got bone. Fantastic. We look at that, we open it, we show it with pride. Boom. Does it match what science says? No. Okay, so let's have a look, because a lot of times, and these are my cases, these are not other people's cases that I'm going to say, hey, because this happens to me. I do all my thing. The patient spends a lot of money. I open up, I take a peek, I'm like, oh shit, don't show that one. Do that one up. Thank God it's a thick gingival morphotype. Okay? Thank God it's a single tooth, because I'll get away with it because it's still in function. But there's no bone over the buccal. Let's have a look at this, because here's a case that I did that I thought I did a bone graft at the top there. How much bone do you think is that? That's almost 1.8 to 2. Would you be happy with that? Everybody. I was happy. Let's have a look at what happened when I opened up. oh, whew, it's gone. And this is what happens to bone that's not stable, bone that doesn't have enough vascularity to maintain it. So it's all very well. And now we look at the scientific data that shows us how much peri-implantitis we have, up to 50%, some of our things showing. With implants that have got exposed threads, which you showed have got such a rough surface, what chance have we got? But yet we still, we want to have more patients. So we'll do things as simply as we can because then we get more patients. And we're lucky because what happens is these things only go wrong in 9 and 10 years. The patient's forgotten that you did the case incorrectly. They just, okay, we'll just redo it again. So we go and we can, like Jack said, we can now go on holiday twice on the patient. There's lots of different techniques that you can employ. I'm not going to go into the different bone grafting techniques. I utilize them all. I'm a periodontist by trade, but I'm an oral surgeon as well, I suppose, not trained, but I'm an autogenous bone person, okay, and I use autogenous bone as a rule because it is the gold standard, and there's no debate, it works better than anything else, and it has the highest success rate of anything else. But I'm not going to go into this. There's lots of different techniques that you can employ. I'll show you some of my techniques, and we'll take it from there. But let's look at soft tissue thickness, because this has really gained significance with Thomas Lenkevicius's new articles that have come out where, and I haven't even put them there because Van Ekkeren's article, I think, said it even better. And Van Ekkeren said that if the initial mucosal thickness surrounding bone-level implants is more than 2 millimeters, I think he could have said this a lot shorter, to be honest. Obviously, didn't write this in English. Significantly less crestal bone change. Okay, so basically, if you have 2 mils of bone, you get no bone loss. If you have less than 2 mils, you get bone loss. And Lenkevicius' study, Berglund, as far back as 1996, they showed already that if you had less than 2 millimeters of soft tissue, you had less bone. So what we now know is that there's an acute symbiosis between the two. If you have nice thick bone, that thick bone is going to protect the soft tissue. And you've all seen it in cases where you've got nice attached gingiva for the first year. Suddenly you come back a year later, the attached gingiva started to disappear. Why? Because there's no bone to support it, to nourish it. And vice versa. So we're looking to create gingival thickness. And again, it comes down now to your soft tissue techniques. Are you able to create soft tissue in the right way? And the soft tissue is not just that way, it's vertical as well. You require vertical soft tissue and horizontal soft tissue to make sure that the bone is stable. And here's one of my cases from 2008 to, I think that's calculator stage. 6, thank you. What? 6? 6 years, okay? So let's look at this case from 2008 and let's look at that side. And you can all sit down and people will say, oh, well, you put that too buckler and you're absolutely right. I used too large an implant, you're absolutely right. But in essence, back then, there wasn't the right gingiva. Whatever happened, the gingiva was wrong. And we look at 2014, what's happening? We're getting a Chewbacca effect. Okay, I love that, Jack. It's my new one, Chewbacca effect. I'm going to use it. I will quote you. Huh? Chewbacca. In South Africa, we say Chewbacca. Okay, tomato, you know what I mean? So if we look at this area over here, okay, look at that area, because that area is not too bad. And then we look, 2014, what's happened? There's no bone. So there was no bone in that area, and everything over the time has shredded, has taken away. But look in the middle, what's happening here? Beautiful, thick, soft tissue. Good bone, and as a result, from the year to 2014, the 6 years, we've got stable and happy. My cases, okay? The important thing is to learn. We make mistakes. The important thing is to learn, okay? But I still make mistakes. And then there's this lady, okay? I haven't got the detail to go in, but this is 7 years post-op. This is 13 years post-op. The only good thing about this is that she doesn't have to go to the fridge at 12 o'clock at night because she can stash her sandwich underneath her, what's the name? She just goes up, you know what I mean? Which is a huge problem. And the better thing is, I'm going to take the entire family on holiday because I don't do all on 4, I do all on 15. You know what I mean? We do what's called a wallet biopsy. Let's look at attached gingiva because this is another fact. And attached gingiva really plays into thickness of tissue because if you have attached gingiva, you generally have thicker tissue. Okay, non-attached gingiva is not going to be. The lack of sufficient height, keratinized mucosa, less than 2 mils, and bone regenerative procedures. So Canulo showed that both regeneration, in other words, you need the bone and you need the soft tissue, were associated with a higher prevalence of peri-implantitis. And for those of you who've been in practice for a long time, you will know that when the most cases of peri-implantitis are the ones with no attached gingiva. You're often having to redo them. And if we look at Burri, increased width of keratinized mucosa around implants is associated with a lower mean alveolar bone loss and improved indices of soft tissue health. So the thicker the tissue, the more attached gingiva you have, the better your implants are going to be maintained over the long term. And this is my case. Okay, wrong bone graft technique, failure to do my job to get the soft tissue right. A couple of years later, okay, things are now, and now I've got a Chewbacca. What did you call it, Jack? Chewbacca, Barker, a Chewbacca. You have a Chewbacca. This one's just a pus. Okay, you have pus over here. Okay, coming out. Okay, and this one's not mine, by the way. I'll claim what's mine, but that one ain't mine. Okay, but this is what we're dealing with. And, you know, we spoke this morning in the speaker's room. We're having lunch. We're talking about how many patients were coming in. You're like, you've got 20 that you're explanting and 20 that you're implanting in the same week. Okay? And that's bad. And why is it bad? Because we have lost, we tried to do things too quickly. And we are forgetting about the detail, the finer detail that's going to create the long-term success. And if you take nothing else away from our lecture, please just listen to that. So let's look at the different cases. And again, these are both my cases. Okay? This one we've written an article about. But we need to separate immediate implant placement into single teeth and multiple teeth because they respond very differently. You cannot do a full case and think that it's just like doing 7 single implants, because it's not. Because it responds totally differently. The collapse that you're going to have is going to be tremendous compared to the collapse that you have with one. So you have to really rethink how you're going to do them. Delayed placement, single versus multiple teeth. Again, we have different protocols for how we deal with the soft tissue, okay, and how we deal with bone, and I'll show you some of the techniques I use. So let's look at single tooth immediate implant placement, okay, which I think is the most common. And the crux here comes down to really the most basic. And we saw, and you see often, especially on Facebook, if anyone's on Facebook, you see a lot of cases where people, can you switch that down a little, please? Otherwise I'll start to dance. Whew. And that's scary. But essentially, the least that you have to do, okay, is dual zone therapy. We take it a little bit further. I don't think dual zone therapy is enough because we have to thicken the soft tissue as well. So if you aren't doing partial extraction therapy, socket shield, the bare minimum that you are going to do is to create some kind of soft tissue graft in your immediate in single teeth. It's absolutely essential because we know from Chen, we know from Boozer, we know from Botticelli, from Quadripoli, we know we are going to get collapse. We know from Schropp that we are going to lose at least 50% of our socket shape. So if we don't do something to improve that, and the least is the dual zone therapy, which is using bone right down to the base, or taking soft tissue and putting soft tissue as an augmentation material, which is going to help to expand the socket so that when everything starts to collapse, everything collapses back into place. And Grunder's study certainly showed that this is exactly what happens. And they got much better results. So if you have a look at what's going on, you can see here putting the soft tissue graft in, suturing everything together. And when everything's finished, you can see there's more bulk there than there is there, and that will stay. Okay? Okay, here you can see still with a temporary, and there you can see the beautiful soft tissue emergence that you create with a single implant. But now I'll ask you each a question. Is there bone over that implant? You haven't got a clue, have you? That's why when people show you a periapical and say, look how good my implant and bone graft was, it's really a con. Because you should have a CBCT to show. If you're going to say you've got bone, show us that you have bone. Okay, it's key. And then I want you to look at another thing. What type of morphotype is this? Is it thick or thin? This is a tough one, hey? Thick or thin? 50-50, ask the audience. Phone a friend. Thick or thin? You want to sit on the fence, eh? Typical Russian, okay?
By the way, Armenian.
Oh, sorry, Armenian. Okay, I retract that. Yeah, that's true, because if it was Russian, you would have marched right in. That's true. Okay, so the fact of the matter is we have a very thick gingival morphotype, because the minute you have a very thin gingival morphotype, you're not going to get this result. And Joseph Kahn's consecutive review that they just showed a couple of cases. But if you start trying to do it in thin gingival morphotypes yourself, it just doesn't work. You get 1 out of 10 cases. And is that acceptable as a thing for us who treat paying patients? No, it's not good enough. So I used this case because this is another one of my long-term cases. And this is a case, patient came in, I took out that tooth. Everything was fine, the bone was there. I decided to do a bit of modification of the ice cream cone technique to try and protect everything. We put a membrane in, we packed bone in. I did an apicectomy on the tooth next door. I retrofitted the crown, which I do as a rule. If I can retrofit the crown, I do. So the patient walks out, I call it walk out as you walk in. That's at suture removal, and this is after proper healing. Everything's fantastic. And we see a lot of these cases. Look how good I am, I'm fantastic. I'll show you a periapical. Oh, look at the bone into proximity. Very good, Dr. Gluckman. Outstanding result. Okay, so she came back in 2010, and what had happened? Granted, everything had collapsed. Within 2 years, everything had collapsed because we hadn't done any soft tissue grafting at the time. So not a problem. We took the crown off. We did a soft tissue graft, okay, using a simple pouch technique. Everything went together, and that was how 2012 she came back. She still got the same temporary crown on. She won't replace it, okay? Which is sometimes a problem because you don't get too many referrals from dentists when they don't come back for the crown, okay? But you can still see this is not looking great, but essentially from a soft tissue point of view, I'm pretty happy. We've got our bulk, we've got everything back, everything's good, but is there bone over the buccal? You don't know. 2016, fast forward, we get to 2016. Now she's having pain where I did the apicectomy. So my apicectomy lasted 8 years. That's fantastic. It's now failed. She phones me. I'm overseas at a conference. She says, got pain. I said, listen, you go and see your own dentist. Not a problem. She goes to your own dentist. Boom, tooth gone. Shit. Because I was really planning a socket shield there, which would have really saved the whole case. Okay, it would have really saved the whole case, because now what's happened is, and you can see there was bone everywhere, he's extracted it and everything's collapsed. Now I'm in the proverbial poo. Because now I've got a situation, look at the collapse as was shown this morning. Okay, look, next door, papilla is gone. Okay, the papilla's gone. I make my incision because I never make an incision on an implant. You raise the flap on an implant and that soft tissue is gone. So we do a sclar flap, we open up and oh damn, look what we find. No bone. So we place our implant because I couldn't do a cantilever from here because it was an ankylos which is non-CX, which meant that if I placed a cantilever bridge, which would have been my preferred treatment option here, it's going to swing. So I have to put an implant in. So we place an implant, we do a sausage technique in this area, PRF over, close everything up, and that's how I've left her. The reason and the point that I show you this case is that this is what a lot of our cases look like. Okay, it really is. And it kind of reaffirmed my need for partial extraction therapy, for socket shield and things like that, and really affirmed what I was doing. So this is the immediate post-op. We will get back to you. You can follow this case on Dental XP because we will be discussing it further. Let's have a look at this case, because in essence, here you can see from 2016, this is where we started at 2008, to here, look how fantastic the soft tissue is. So the question is, why do I have such good soft tissue? Why hasn't things collapsed? Well, I've got thick enough tissue because I did the graft. And thick enough tissue can stay. So just because you see a result that they show you with a periapical that shows good soft tissue does not mean a bone graft technique has worked. Okay. And here you can see what happens here also is that the bone on the adjacent teeth will stabilize and support a thick gingival morphotype case. A thin gingival morphotype case will collapse and you will see it. There you've got no choice. And that's where socket shield is absolutely critical in that type of thing. Okay. So let's take the next step forward, because now what happens, okay, let's leave that behind and let's look at this kind of scenario, because here's another option for you. And I think this is brilliant. This is from Carlos de Rosa, immediate dentoalveolar reconstruction. What an outstanding surgeon. What a brilliant, brilliant guy. And when you talk about thinking out the box, this is completely in the next room, okay? And what he showed, okay, when you have a dehiscence, okay, where most of us will extract the tooth, some of us will try bone grafting at the same time, which generally you can't do with most of the techniques. Synthetic materials do not work. Putting a membrane in here, closing it, it just doesn't work well. Very unpredictable. Okay, so if you're trying to do it and it's not working, you think it's your technique, it's not. You're being bullshitted. Doesn't work. But his technique does work, and he's got I think now 10 to 12 year data with CBCT showing fantastic results. And this is one of my cases that I did, one of the first ones. So this patient came in, they had a fracture, and all the bone on the outside had disappeared. And you can see there, if we just show that, you can see the great dehiscence there, which is about 8 millimeters long. Now, what Carlos does is he goes and he takes tuberosity bone. Now, tuberosity bone is very different to other bone, because tuberosity bone is usually type 4, type 5. And type 4 and type 5 bone is fantastic because it's very vascular and there's no cortex. Cortex is bad bone to graft with. Okay, and we'll talk about that later when you're talking about autogenous blocks. Okay. But what he does is taking that trabecular bone, the turnover of that bone is so quick, and it gets revascularized so quickly that it becomes new bone and new lamellar bone, not new cortical bone. It gets the lamellar bone that can handle strain, that has got rich numbers of osteocytes. And remember, if you have osteocytes in your bone, it will be able to determine stress, and therefore it will stay. If you have osteocyte-free bone, the body doesn't know that there's stress, because the osteocyte's function is to control the breakdown and deposition of bone. Okay, and the thing. So what we do is we take a piece of bone, we shape it in a very specific way, and you can go and listen to his lecture on dental XP. It's really cool, and he's a phenomenal guy. And he basically packs it into that area, the implant's placed, and you pack all the rest of autogenous bone. So it's only autogenous bone that's packed into that area. We put the healing cap on. I brought the patient back to be, look, you can see how I've pushed it out. We put a provisional on straight away. So this is fantastic. You're doing a bone graft. You're giving the patient a provisional same day. Okay, fantastic. Unheard of, not possible. And you cannot do this with synthetic materials. Forget it. It is not possible. Okay. It's only possible with this thing. So when I sent this to him, it wasn't great the way I did it. And he kind of, he gave me a few tips on what I should maybe do next time better, etc. But the essence is, this guy came back, I think this was about 6 months, and you can see here beautiful. In fact, this was lower, okay, which was great because I've got a provisional now. Now I can now take my time to slowly expand the soft tissue, develop the soft tissue, develop the zenith so that it can be done properly. He subsequently disappeared, okay, but you can see great surgical lines. When we take a 6-month post-op CBCT, and the CBCT is now 3 years old, it looks exactly the same. We have got now 3.5 millimeters of bone on the buccal. If we look at the soft tissue, this is now him coming back 3 years later. It's now, okay, maybe I phoned him and I said, please, can you come in? I need the photos. Okay, and he came in and then I said, please go and see the guy. You can see things haven't receded too much, about 0.5 millimeter, but we're well in the frame. And then my prosthodontist, the guy that was working with me, started developing it. And there you can see with the final crowns in position, okay? And with phenomenal bone in position to keep everything going. Okay, so those are the two issues that you could do with... Richard really likes this thing. He's a bit strange, okay? He says he gets excited when he sees that photo, so I put it there for him, okay? Yeah. You just better stand away from him there. I don't know what's going to happen. He's like, stand back. I don't know how big this thing gets. Okay. So anyway, when we're looking at multiple teeth, okay, and this is my own preference. This is not something you have to do. This is purely my own preference, and this is purely the way that I treat my patients now. But because of the collapse that we get, when we're talking about multiple sites, okay, I use partial extraction therapies almost as a rule, okay? And you can see this guy's a honey farmer, and you can see he's been eating more than he's been selling. And as a result of that, everything's rotten. Okay, there's no point in trying to restore because your margins are going to be on dentine. He's not stopping eating his honey. So this is an ideal case for partial extraction therapy with socket shields, 2 socket shields, root submergences. Jack, I don't like the all-on-4 process because I'm more a Mike Picos kind of guy. I like to, charge a lot more and take the whole family on holiday. But in essence, what we've done here is we've created the environment that will prevent collapse, not for 1 year, not for 5 years, and not for 10 years. This is going to stay stable as long as we don't have any issues with the teeth. And so far, to the date that we have, and with the 14-year data that the Greek group has, we are not having those problems. And certainly it is something that I'm not having, and certainly the guys that we're working with. So here you can see immediate load, immediate provisionals. As much as I'm a periodontist, I do all my own immediate load, okay, for the pure reason that if I'm going to take responsibility for the failures, I want to have responsibility for the load. And if I'm going to take responsibility for the soft tissue design, I want to take responsibility for the provisional. And here you can see the final results. In this case is about 4.5 years old with everything intact. Look, we've got a full lower, a full upper, and look at the emergence profile. Look at the amount of attached gingiva that you've got, which is stabilizing the whole process. There are lots of other ways you can do it. You can do the all-on-4. I'm not saying, and I'm not pontificating, saying this is the way you have to do it. This is the way I do it. There are lots of ways that you can do it. And if partial extraction therapies is not for you, there is the all-on-4, there are the all-on-6, there are all the other concepts that you need. But just bear in mind that when you are doing those techniques, you need to develop the tissue properly. If you don't have bone, you have to grow bone. If you're not able to grow bone, you need to refer the case. If you haven't got soft tissue, you need to develop the soft tissue, and we'll talk about that now, because now it comes down to, we've been dealing with the immediates, now let's talk about delayed. And let's talk about single tooth delayed, because these are very, very different. Now, as far as bone grafting goes, you can use whatever you want. Okay, I'm not here to tell you what you must use. If it works in your hands predictably, use it. Okay, but don't bullshit yourself. Go and take your CBCTs and see and confirm that what you are doing is actually working. Okay, there are many different techniques, but one thing that I have found is what I call the aesthetic exposure, and we've prepared the manuscript. This is a technique that I've developed for exposure in single tooth sites, because I see a lot of people doing the papilla saving incision, which in my opinion is one of the worst type of incisions that one can do, because it has so much scarring and it is really not an ideal type of situation at all. This technique is a technique that I've developed over the last 2 or 3 years, or maybe 5 years, I can't remember. And what we do with this technique is we do a modified tunnel, okay? This is a peninsula, what I thought was a Pennsylvania, until until Chuck said to me, that's Glas Pennsylvania, what's it? Peninsula, that's Glas Peninsula flap. Oh, okay. So I was a little bit of an idiot for a day. Thanks, Chuck. But this is basically a U-shaped incision. Now, Sklar developed the peninsula flap, which is basically the other way around. So we just turned it the other way around. Now, I think Andre Sadun did that already, so that's not new. What I did is I combined Andre Sadun's technique with the tunnel technique, okay? And that tunneling makes a massive difference to the success and to the ability for you to manipulate, because for anyone who's tried to put tissue on the buccal with just creating a little pouch, 9 times out of 10 you push down the one side and that piece comes up. You push that side and that piece comes up. Do you know what I'm saying? You've all had it, eh? It's a nightmare. The minute you create the pouch, and I'll show you what we do here. So this is the shape of the pouch. It's exactly like you would do a Pat Allen or Marcus Hertzler tunneling technique. But you are creating from one side of the tooth to the other, you're creating that entire pouch, which frees up the whole area, and I'll show you a video of it. Then we take a piece of connective tissue, and that one you can see, you have to be really good to make your connective tissue look like a glove. Okay, I sit for hours trimming, okay, under very high magnification. Okay, we put everything in, and you can see here, the nice thing about it is that we have not got any scarring. We are already pulling the papillae because we've got movement, because we've released right up into the vestibule. We've taken all the movement. We can now mobilize the entire buccal portion. It gives me lots of space to put my piece of tissue in, so the tissue sits in easily. And the second thing is I get to fill in my papillae because I can coronally reposition that as well, which also leaves me with a great problem of being able to now develop my soft tissue profile. And then we can get great results. And this one I haven't shown you, but this is a massive bone augmentation that we've done. But most critically, if we look at this, why do we get that result? Because okay, so there you can see where we've put the piece of tissue. And here you can see why have we got a good result? Because we've got good bone. We've got 2 millimeters of bone on the buccal. With the 2 millimeters of the bone on the buccal, we'll have good soft tissue. With a good soft tissue, we'll maintain our bone. So we'll get a good result over the long term. So let's look at a little video of this case. And here you can see this is a case where I placed the implant in. We did a sausage technique in this case, not my preferred technique. And you can just see how we did this case here. You can see with the exposure. So this is what we started as. And that's what we finished as. So it's a massive augmentation using sticky bone. I don't use Istefan Urban sausage technique. We're busy doing a study with Botus, who's not available in America, on the sticky bone and their Jason membrane alone, the Jason fleece. Jason, please. Richard just loves the fleece. So here you can see what we're doing. We're creating the whole thing. You can see I used my stent, okay? And if you are using stent-free, which I see a lot on things, you shouldn't. You should have something to market, okay? You shouldn't have any of these instruments that tell you, because from a prosthetic point of view, it is stupid to use something that just gives you a general thing, because no patients fit into a box, okay? You should have a stent. We take out the cover screw. We test the ISQ, okay? Okay, because I have one, okay? I actually don't. We just made that thing so it looks like I've got one.
That's all right.
Yeah.
It's a good thought.
Because we're from Africa, we don't have that stuff. It's not imported there yet. We probably could, yes. Africa's great, you just have to pay. Here using very small ophthalmic blades to get inside there. And basically just doing a split thickness flap, okay? Splitting the tissue, leaving the periost behind. And you can see going right up to the top there, it's not just past the mucogingival junction. That is the key to success, because if you don't go past the mucogingival junction, you will never be able to mobilize the tissue. If anyone wants to video this, you can. It is on Facebook, it is on YouTube. You can download it, you can do what you want with it. I do not care. Use it, and if it helps and it works for you, you can have it. You can even claim it's yours. Okay, so now we're using tunneling instruments, and you can see just by the mobilization how we're starting to get good mobilization of the tissue, and we've mobilized all the way through from the one side to the other side. You can turn the music up just a fraction. That way there won't be any awkward silences. Okay, so spending a lot of time mobilizing everything, going to grab a little piece of soft tissue, and I'm just going to shoot through this because you're going to see how to harvest soft tissue. And that's not what I wanted to do. Let's just play that again. I'll just go through there quickly. Okay, so we harvest our soft tissue, we take our piece of soft tissue out. Obviously, there's lots of different techniques to harvest the soft tissue. And what we do then is we now take our piece of soft tissue and we pull it in. Usually what I do is I suture it from one side to the other. I don't usually do this technique where we just push it in and tie it afterwards. I like to stretch my soft tissue. The more you stretch the soft tissue, the more stable it's going to be. Remember, soft tissue like bone requires stability. If you're trying to put soft tissue in and you leave it loose and it's mobile, angiogenesis can't take place. Those endothelial cells aren't on crack. Okay, they're slow and sluggish. They need time. They need effort. So what we do is we put it in. We de-epithelialize the top part. And sometimes if we've got great bone on the outside, because even with the big reconstruction that I did here, we still had the collapse. And this is what you were alluding to about the fact in Versah's study, when they did a lot of delayed stuff, they had the ditch. And even after the big augmentations I was doing, you still had the ditch. And this is why, because most of the bone that we put in there resorbs. So in this case, this is just a different technique. We're just putting a sling suture in, which will just pull some of the tissue coronally. Just to give you an idea. And I just want to go through these quickly. Okay. Chewbacca. That's C3PO, sorry. Got the whole cast here today. Okay, so these are what we call bonded sutures. For I don't know who's used bonded sutures, but these are the easiest sutures to do coronal repositioning with. They are so easy to bond the tooth next door, and you just pull them up, you turn them over, and it's quick and easy. It's a very simple way to stabilize your vertical. Just pop a little bit of composite on the adjacent tooth, and you get wonderful coronal repositioning of it. And that's when they come back, we place there, you can see, place everything in track. There you can see with the provisional now in place. And that's where the patient is now, 10 days post-op with us. Okay, so the technique is phenomenal, and it's pretty much my bread and butter now. And the success rates and the amount of cases that are now in the top 10 rather than in the bottom 5 has gone dramatically higher. Okay, because of that simple technique. Unfortunately, though, in a lot of the narrower spaces, like your congenitally missing laterals, you cannot do it. And what we generally do, I'm going to go through as quickly, is we do just a modified Palacci, where we create a T-shape and we flip this piece to one side and that piece to the other side. One thing that's critically important when we're doing this, a lot of you who do these kind of techniques where you just raise the flap on the buccal, you will find that you get clefts forming, am I right? As soon as you try and put the soft tissue back, it sits a little bit away from the gum, and when you see the final healing, you get a cleft. Does anyone see that? The quickest and easiest way to fix that and to stop that happening is to do a tunnel from there to there, because that will mobilize the whole side tissue and will allow the whole piece to sit in far easier. So you won't have that clefting anymore. Just increase your incision this way, from there to there. Just increase the tunnel. All right, so let's look a little bit more at a little bit more of the difficult stuff. Let's look at the vertical and horizontal augmentations. And here you can see this young lady was in a car accident, and obviously that's quite a hell of a thing. They left the tooth in position. It was mobile and fractured, and unfortunately, obviously, it destroyed all the bone. So what you'll see is a protocol here that pretty much we follow as a routine. And it doesn't matter what type of bone grafting or augmentation procedure you do. If you have a different way that works well for you, go for it. There's no issue with that. For me, when I'm doing vertical, autogenous bone is key. And you'll also notice that we are using very, very thin plates. And the reason why we are using such thin plates is because the thinner the plate, that piece of bone is not important. What's important is the autogenous bone chip that we put in between. We do rotated flaps in single sites to get everything together. We open up after 4 months, and that's what we get. And the great thing about this is where your densification really will make a big difference. Okay, and we've done a number of our cases now with densification, and certainly because this bone, it looks fantastic. Okay, it is fantastic because it's the best quality bone that you can have. It's not full of xenograft or anything else. It is absolutely wholesome, smacking, deliciously finger-licking good bone. Juicy, yes, juicy. Thank you. I was looking for that word. I wasn't quite sure. And if we have a look again, the same protocol is followed in all of these cases, but I'll show you because we made a bit of a mess of this case. You could see there, just go back there, because what you can see here is you can see, despite everything that I've done, massive augmentation. Do you see that? I still have a deficiency. So if I don't do something about it, my case is going to be a nice case. It is not going to be a great case, and I want all my cases to be great. Okay, and that is what most people want. Okay, and here you can see the same technique that we're using, the technique. And we placed our piece of tissue in, we've sutured there. And my mistake here was that I sutured it here and I didn't go far enough over to that side. So when it healed, I had a cleft. Not a cleft, but a little bit of a dip there, which unfortunately I'm just not happy with. I'm a bit pedantic. I don't know what I should call myself, but I'm pedantic. Okay. And so as a result of that, thank God the patient is one of those patients that's looking for perfection with me, which is great because you can really work a lot with these patients. And a lot of these patients, we don't charge for these kind of things because now it's like a second procedure and, you kind of want it to show at conferences. So you say, no charge to you. She doesn't realize that it's just for the photos. And here you can see this patient is now healing. You can see there we've got a much better profile. Nice papillae there. We'll wait for that papillae to fill in, and then by the time the prosthodontist or restorative dentist gets this case, everything will be perfect, and it's just a matter of now of doing a customized impression to recreate or develop further depending on the needs of this case. So let's look now at multi-sites, because multi-sites again are a very different kettle of fish, okay? And I'm not a big ridge splitter. I do a lot of ridge split, but I don't do a lot. But I want to just take 1 minute, okay, to share this with you because, again, whenever anyone stands up here, you can never be prescriptive. You can give ideas, and I think it's very important for you because not all of your patients will fit into this category. And Jack, I think you said it categorically. There are some patients that just want it now. They want their teeth out. They want this done, that done. And I mean, what's the point of letting them go down the road to somebody who doesn't do it properly? Rather let them pay me and do it. If they want to do it, fine, as long as they understand the risk and as long as they understand what I'm going to do in the long term to make sure it's right. And this is perio patients. Perio patients are a huge factor because the peri-implantitis risk in these patients is very, very high. And if I can, okay, I want you to have a look at this as well. Have a look at this case, failing implants, peri-implantitis. If you look here, there's no bone up here. That means when I make an incision and cut that off, all this is unsupported, which means that all the attached gingiva that I require is going to disappear. Unless there are techniques where you can do split thickness and apically reposition it, etc., but I haven't got time to go into that technique. But this is the issue that we're dealing with, okay? Here you can see the type of issue. So here's a young woman. So now I've got a woman with very aggressive periodontitis. She's lost her teeth. I think she's about 39 years old and she's lost all the stuff. The last thing I want to do is go and do immediates in this case. I want to develop my soft tissue because she's got another potential 60 years to live with whatever I'm going to do. Okay? So what I do in these cases, I would tend to step back. And instead of trying to be the hero in the case, I'm going to try and slow it down so that I can make sure that I do everything 100% perfectly. We open up. We've got nice bone because we've extracted. We've allowed everything to heal. And usually these things do because they lose a lot of vertical bone. Okay, so the bone is nice and flat. And there was a question yesterday about, well, somebody asked a question. They're probably not here anymore. They asked about, does PRF have an impact on on bone healing? And this is an article in iJomi 2015 where they showed categorically this is a controlled clinical trial where they did 2 teeth next to each other. One, they put PRF membrane into the extractions, into the osteotomy, and they put PRF liquid into the one. The other one got nothing. And the results were that the ISQ values, okay, which were shown yesterday to be very crucial to our determination. And it's certainly, as you said, a great objective test rather than the ting, ting, ting that we used to use. Okay? But it showed categorically that there was not only a statistical significantly higher ISQ level, but a clinically significant one as well. And as a result, this is another biomodification that we now utilize as a rule in all our cases. So here you can see in these front ones, I cut them into half, and I place a PRF membrane into each one of the sockets. And then we place the PRF into the implant into liquid, and we screw everything in. And there you can see R2D2. Actually, no, that's Wally. That's Wally. Hey? Is Wally? Wall-E. Wall-E. Okay. Again, osseodensification, utilizing all the techniques that we can to enhance the sites. You can see the beautiful halo that that's shown in this case, which is really, I think, just gives us a categorization of what it is. Soft bone, beautiful. Great to be able to enhance this to the maximum. Every bit of biology that we can use to get things going, we do. And here you can see now the critical issue is, do I now do it as a one stage? And the answer is definitively no. Because if I do this as a one stage, I'm going to end up with poor gingiva. And a lot of people will come in, well, let's go in there and punch. Quick punch, take me 2 seconds. Punch, 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 punch. The only thing we use a punch is only for hitting people in the face with. Okay, you need to develop your soft tissue. A punch takes away tissue. When I see people doing guided surgery and they're punching and they take all the attached gingiva away, it drives me nuts. Okay, but I'm seeking therapy and it's working now. Prozac's fantastic, actually. They haven't stopped smiling for weeks. Okay, so we closed everything up and we come back at integration time, and now we use this next time to now develop our tissue. Because now what we are doing is we are doing a split thickness flap, and I'll show you a video on the split thickness flap. But here we raise a split thickness flap, and we don't now try and suture. We put our healing abutments on. We don't try and suture this part to there. We suture that down to that flap, and we make sure that it's immobile. Those guys that were at the soft tissue course, we did this, we practiced it, and we got a good thing about this. And what this does is you need to make sure that that tissue is absolutely stable and immobile. You do not want it over the top of the abutment, because if you put it over the top of the abutment, it disappears. It is not effective there. But what will happen is that the tissue that's here will expand back because it has a genetic fingerprint. It will come back. And if you see what this looks like at the healing phase, the prosthodontists among us will smack their lips and say, yeah, baby. Richard? Oh, yeah, absolutely. Now this is protecting the bone and the soft tissue. Sexy, eh? Like fleece, baby. Yeah, but okay. That is what we're looking to achieve. Yes, it takes a little bit more time. But the fact of the matter is we are not in a sprint. This is a marathon, and it's a very long marathon for this patient. So we need to do everything that we can to make sure that the patient gets what they can. Again, multiple cases. I'm going to rush through this, but never mind the augmentation procedures. But I just want to show you the type of level that we go through to develop these cases, using stents, using autogenous blocks, Curry style. Here you can see at exposure with implant placement. I don't know where the intermediate slide went. But here again, what we've done is we've spent the time to do the apically repositioning of the flap. Where we've got this big gap, we don't leave it. We go and take a little piece and we go and suture it in, and then you feel like a real big surgeon because you work under a microscope with tiny little sutures and you feel cool. Yeah, I'm a surgeon. I check that little piece. Very cool. And when the patient's finished, that's what it looks like. So not only have we taken the time to develop the bone, not only have we taken the time to develop the soft tissue, but now when the restorative guy gets it, and listen, there's no ways I'm going to be able to build back that stuff. It's just not possible. Okay? But what we are able to do here is give the patient a long-term chance of success. Okay. So let's look a little bit. This is multiple teeth. This is a Curry style technique. Here you can see a 13 millimeter defect. And the way we handle these type of things, I've got about 5 minutes, we should finish. What we do in these kind of cases, we do a tunnel technique, and Bernie, you spoke about single incisions. This is classic. It comes, the single incision comes from Foud Curry. I'm just going to go through the harvesting of bone. It doesn't really matter how we harvest the bone, but essentially what we do is we split the bone up. Because the key with these techniques is we don't want this cortical bone. This cortical bone is dead as a doornail. It is worthless. It resorbs over time because it has not got any cells. Okay, what they're called again? Osteocytes. Okay, they don't have any osteocytes in. And this technique is carried out because when you're doing vertical incisions, when you're doing vertical grafting, one of the biggest problems is wound dehiscence. And because we have more than 2 teeth, we have to work through one incision, which I can tell you now ain't easy. We raise the flap, we put the first one in. You can see that. I'm just going to go through this quickly because this is not what I want to show you, and we don't have the time. So here we smooth everything off, pack our autogenous bone only into the area. We put another bone plate on the outside and we screw that bone plate into position. There's everything getting screwed in, sewed off. We put a little bit of PRF over the top. The PRF, as we know, does not do anything for bone. Okay, it doesn't do anything for bone augmentation. There's no scientific data to show that it does. but it does improve wound healing and soft tissue healing, so that's something we do. Now, the 2 teeth that you see behind here, they were both earmarked for extraction because they were badly decayed. So what we did here, you can see there, that's what it looks like after everything's finished. 1 suture to close everything up, and you can see the width and the height of the graft. And there you can see that's at 1 month follow-up. Everything's healed beautifully. You can see how much vertical. You can still see the horizontal augmentation that's in place. Okay, there you can see the CBCT of the high amount of thing we got. Now we're going to do a socket shield a root submergence on that, because why take it out? Keep it. We extracted that one because it was too bad. We couldn't keep it. We opened this up at the same time. We placed our implant in position. And we closed up, and 3 months later, this is the ridge that we have, okay, which is not bad. We've got a great ridge. Now we've got, from a 13 millimeter defect, we've got a great ridge. But now, this is where everything goes awry, because now we've got the bone. We're like, yeah, baby, I'm cool, I'm good. Got 13 mils. I can now just do a punch, okay, punch in the face, okay, because now comes the critical time to actually do things properly. And here you can see with this technique what we've got. Look how much our alveolar mucosa is. So we're now going to make our incisions deep into the palate so that we are going to generate a lot of attached gingiva and place it to the buccal. We leave 2 millimeters of space between our implant and our tooth. We leave space so that we can suture to that 2 millimeter finger. Okay, it's the whiskey hitting in there, Sam. Hey? The whiskey's hitting. Okay. Here you can see we leave a little bit of space. This is a very nice tool. It's just a little bit of, it's something that we can just helps you with split thickness flaps in the palate. It's much cheaper than getting the blades that actually bend. Okay, you can buy this at most companies. And you can see there. So what we do now is we slowly get it to the right angle, tighten it so that we've got it working at a nice 90 degrees, working with a pair of micro forceps. Slowly, and all we need now is 1 millimeter. We don't need 10 millimeters of thickness, so don't try and take as much as you can. Take as little as you can. 1 millimeter is fine, because what happens is that when you move the tissue from the palatal to the buccal, it expands. I'm nearly out of time, so I'll finish after this video. Huh? Yeah, no, I've got another speaker, and it would be unfair to him. Totally. Okay, so here you can see taking the screw out of one of the deeper screws that we left behind, because we can see it. Notice how far I take my incisions. The incisions must go very deep up into the vestibule. If they don't go deep up into the vestibule, you will not be able to manipulate the tissue properly, and it will all scrunch up, and you will get poor attached gingiva. We now open up our piece of tissue. Put a low profile on. This patient also had some orthodontics to move this tooth into position because it was a little bit drifted backwards. We do our ISQ, which we do for everything. I'm just going to go through this quickly. 79. Whoa, check at that. Hey? 79. Close, Isaac, eh? Nearly the same as yours. So here you can see what we've got. We've got that whole thing denuded, but it's got all the perios behind. Now what we start doing is we start to suture everything together. Now, I'm not trying to pull this part to the inside part. I'm suturing it down with periosteal sutures, and I'm making 100% sure that that tissue is not mobile. Okay, I think I'm over my time now by a minute. So I'm going to quickly go through this. You can see there very fast. Just watch very quickly, okay? And I'll talk very quickly. But essentially what we're doing is we're tying it down. We're not trying to close everything off. We're stretching it as much as we can. Putting everything. And the key issue here is stability. The key issue is lack of mobility. And by putting that extra suture in with not a lot of tension, so what you can see now, when everything's finished, that's what it looks like, and we leave everything open. And the first thing that people say is, but hold on a second, because what's going to happen, it's going to leave a gap. Okay, we use low-level laser therapy to try and get improved healing using the EPIC. And once everything's healed and the crowns are in, this is what we achieve. Because what happens with the soft tissue is that the soft tissue expands because it's coming from the palate. And when you have a look at what the soft tissue looks like, and with the ovate pontics that we can try and create, you get amazing, amazing, amazing soft tissue, thick soft tissue that will allow you now to get the emergence profile that you want. And you can see there, not perfect by any means, but on a 13 millimeter defect, I don't think perfection was what we were looking for. This is pretty much as close as we get. So I'm just going to quickly go to my conclusion slide. And in conclusion, failure to optimize your sites can lead to long-term failures. And I want you to really take that home. Okay, there isn't a quick fix to anything that you have. You have to spend the time doing things properly. And we have a fantastic sale that is all you have is a hammer, then everything looks like a nail. Okay, it is your duty as a practitioner to go out there and learn new techniques. Okay, and with that, Salah, I say thank you so much. And I think a huge thank you to you. As I said to him in the beginning, you know, he said to me he wants everyone to look classy and stuff like that. And I said to him that class does not come by the tie or the dress that you have. Class comes by what's in your heart. And you have that class. And I say thank you very much. And I wish you all the success.